quality of life, illness representations, especially among chronically ill populations. I invite Dr. Mahati Chittem to kindly take over.
I just wanted to very quickly say a couple of things about Mahati Chittem and before handing it over to her while she's getting the presentation on. One of the things that Hyderabad Urban Lab and me particularly as an individual has been trying to understand is the way in which hospitals in Hyderabad have been working. Part of the reason why we are interested in hospitals and how they work is because we keep talking a lot about corporatization of hospitals, but we don't quite understand what are the implications of that for households and families, right? Especially when people know or sense that there is death imminent. It does a lot of things to the households. People keep struggling with how to deal with the idea of death. Hospitals keep trying to push it away from one's consciousness in some ways and also try and push it into your face in some ways. And what we figured over time is that there is a lot of reality here that is hidden from view, and we need to try and find ways of probing what is going on in these spaces if we have to make sure that people are going to live some sort of a decent life. So in that connection, we've been having a lot of conversations with Dr. Mahati Chittem, and she has been involved in two different tracks that I could see. One is terminally ill patients and their families, and the other is what happens when someone is diagnosed with cancer. At what point of time along the way is it diagnosed? How is it then treated? Does it matter at what point of time it has been diagnosed in terms of the outcomes, right? So those are the two major areas in which I have seen her working, and I thought that it will be very important for us to hear what her work has been all about. So.
Thank you, Anand. Hi. So I guess that was a super lengthy introduction. I've never had one like that before. Thank you. So I'm an assistant professor of health and medical psychology at IIT Hyderabad. I've done my master's and my PhD in the UK. All of it is on psycho-oncology, which is a fancy word for the psychology of cancer. Ever since I came back to India about 6 or 7 years ago, I've been focusing more and more on cancer and now a little bit more on diabetes and other life-threatening illnesses. So today I wanted to nest the talk within the theme of the Dodin, which is precarity. So we are looking, as Anant has already said, we were looking at how patients end up where they do, especially in cities. So there's a huge cancer burden. I mean, if any of you have, if you've gone past Indo-American Cancer Hospital, it's hard to miss the people on the lawn spaces there near the bus stops who are just waiting around because they don't have anywhere else to go after their cancer treatment. They just stay there for their next dose of chemo or radiation. So that kind of triggered my thoughts on why is this happening and why is there such a huge cancer burden? So in light of that, I just wanted to give you a quick background on psychology research in the space of cancer, especially in India. One thing that most researchers have connected, anthropologists, sociologists, psychologists, is that there are these cultural representations of what cancer means. So just like Anand has already said, cancer immediately means I'm going to die. So once you think that you're going to die, you sort of lost the battle already. And the other thing is that it also influenced how you sought behavior. So that's like a health psychology word which we use called health-seeking behaviors, which basically means that, when somebody knows they have cancer, also because of the stigma of the word cancer, and the lack of knowledge about the fact that it's not a contagious disease. A lot of people try and ignore it and don't seek help. So that was another that was a study that kind of backed up my thoughts that this is probably one of the reasons why there's so much of tertiary care burden when it came to cancer. And a colleague of mine, Sangamitra Pati and Santosh Tetravedi, had also published papers that looked at what was leading to late presentation. Late presentation means anything beyond stage 3B, stage 3C, where the cancer is more or less metastasizing, or more or less it's not a nice prognosis, basically. And what they'd found was that there's structural barriers to care, admittedly, but also there's a poor knowledge of cancer, and there's a lack of communication between the patients and their providers, both at the primary care level, secondary care, and tertiary care as well. So that was a very troubling kind of finding that we'd come across. So just to kind of give you a quick brief on the kind of research that we're doing in cancer, which kind of led to why we're looking at navigation. We looked at topics like non-disclosure of cancer, diagnosis, and prognosis. So my PhD was on non-disclosure of cancer diagnosis from several stakeholders. So from the patient's point of view, from the caregivers, and from the physicians. And we did a mixed method study, so we used qualitative and quantitative data. And we found a whole bunch of stuff, which I'll be talking about in the next slide, but not right now. And this was like, God, I feel very old now, but I think it was like maybe 10 years ago or something. So from there onwards to now, we're starting to look at non-disclosure of prognosis. So that's what one of my PhD students, the picture on the top, Shravanti Maya, is looking at. So it's kind of cheering in a way to know that patients now know and can identify with their disease. And we've also looked at topics like supportive care needs. So what are the needs that patients say they have? What are their, if they use a different word for cancer, because you don't use cancer in regular conversation. I've seen educated and non-educated people do that. They'll call it a tumor if you're educated. Otherwise, you'll call it, my stomach ache or my throat pain, something like that, my fever. But people don't use the actual word for cancer. So we were very curious to see if you use the word, how do you behave? And if you don't use the word, how do you behave? Because there's a lot of research from the West that looked at diabetes and obesity and lung issues, and saw that there's a relationship between using a euphemism versus not using a euphemism in terms of acceptability of the disease, and also listening to what the doctor tells you to do. So we kind of, we're looking at the data right now, and it's pretty interesting stuff in that we've discovered people who use euphemisms don't cope as adequately with their cancer as those who actually use the word cancer. We've looked at the concept of what surviving cancer really is. This is with a colleague in Australia, where we are debating that surviving cancer does not mean you have to be biomedically free of cancer. The minute you're a cancer patient, you started surviving your cancer already. So that was our major argument. It was a large qualitative study. We've looked at end of life, we've looked at patient satisfaction, we've also looked at general population to gauge attitude toward cancer. And what we found overall was that, first of all, there's a lot of complex interplay between the patient, caregiver, and provider. And that's just the tip of it. When I started looking through the large qualitative data we've got, we'll see that culture plays a role, your community plays a role. If it's a kid who has cancer, then your school plays a role, your employer plays a role. So it's very complex, this business of being a cancer patient. But more importantly, what we found was that patients know exactly what they want. So something both experientially as a researcher who goes on site and as a person who's actually sifting through all this data, I've discovered that anyone who's not the patient assumes that the patient doesn't know what they want. So right from the time, and anyway, medical decision making itself is a family-centric experience. So right from the time that you were born, you made decisions taking everyone into your fold. So 10th class, after that, what did you do for your 12th grade? Everyone decided So I ended up doing business math, and I can't do 1 plus 1 even. So, my parents made that decision for me. And the same thing goes on and on. So, decision making in itself is a very family experience. And now imagine having a disease. So, but what happens in that decision making endeavor is that a lot of the stakeholders assume the patient doesn't know what they want. So the patient is almost like a child being coddled. And so it was like an unexpected finding. This is not what we had gone out looking for, but we stumbled upon it in multiple qualitative studies. It's not something you can measure in a quantitative study anyway. And then we were like befuddled by this, because patients were saying, well, I want this family member to do this for me. This is what the doctor is supposed to be doing, and this is what my caregiver is supposed to be doing, or what I should be doing, what the nurse. So they were very, very clear about what they wanted and who should be providing that care for them. So for for us, that was very striking, and it had nothing to do with education. We assumed that this is going to be like upper middle class kind of patients who are for the lack of a better word, more empowered. But we found that even it cut across basically sociocultural strata. So, however, one thing that that's great information, but we wanted to know, okay, so if patients know what they want and who should be catering to these needs, then what's preventing them from communicating this, or what's preventing a two-way communication? And that's when we discovered that the cultural representations of cancer being this burdensome disease, and the lack of resources, especially a facilitator of conversation. It's amazing how life can just go by with the closest people in your life not knowing who you truly are. And especially in a medical scenario, everyone is feeling embarrassed to burden the other one. So the patient is trying to handle as much as they can, the caregivers, and they're so busy in the handling process, they forget to talk about what really they want from each other. So we've noticed that there's lack of facilitation of conversation to talk about what really matters, to talk about feelings. And the unwillingness to disrupt its existing dynamic. So if they've already got, a sort of relationship that they're sharing within this cancer paradigm, they didn't want to upset that at all. And so I've had a couple of anecdotal experiences, I guess, especially in terms of the lack of resources, in terms of facilitator conversation. So we've done these workshops with patients and caregivers to kind of get them to start talking about feelings. And it's amazing how quickly the conversation goes into thinking rather than talking about feelings. I think I feel blah, blah, blah. No, not I feel blah, blah, blah. So we realized just how difficult it was, even in a role play scenario, to get people to start talking about feelings. And it was even more difficult. It was easier to say I love you and hug each other at the end of the workshop. It was harder to say I feel disappointed, I feel annoyed, I feel lost, I feel clueless. So that was really striking stuff. Anyway, and another thing that we largely found through all of our research in the past decade or so is that any other word but cancer is fine. Let's just use anything else but that. And now our euphemism data is showing that that's not really helpful. We've started the qualitative arm of the study, and again, we've discovered that using a word that is non-medical is great in the short term, but in the long term, it's not helping them cope adequately with their disease. And finally, fighting the disease is paramount. A couple of our studies, especially the end-of-life study, where we were asking questions on DNR and euthanasia, kind of revealed to us that there's a karma discourse, but it was important to fight the disease no matter what. And that brings me to the question of, what's then the burden that the hospital has to bear? What does the state have to bear? Because if it's a palliative care scenario and the patient is still ending up at the tertiary care center, not at a palliative care center, then the tertiary care center's one bed is lost for a patient who has no future in terms of the prognosis. So that was another highly, like, we've been rejected by an entire journal simply because, we've argued that, they shouldn't be provided, they should be told that, the fight is over, so let's try and make our life much more comfortable, because they're also losing precious time in just fighting with each other, fighting the disease. Right, so what we wanted to do next is we wanted to map patient navigation. This occurred over the course of doing all our research, but also because we were talking to collaborators across India, and we've discovered that a lot of patients present at a late stage, but also a curable cancer has become now an incurable cancer. So we had a nested question about, being that I'm a psychologist, I was curious to see what are the predictors of, not seeking help. So we interviewed 600 cancer patients across 3 different types of hospitals, a regional cancer center, a corporate cancer center, and then a mixed charity-based hospital. We interviewed patients at the time that they were at the hospital for a medical appointment. We asked questions on symptom identification, symptom reporting, treatment decision-making, treatment experiences. And we've done very preliminary analysis. I'll admit right away that I'm crap with quantitative, I'm awesome with qualitative. So I'm not going to be putting numbers there just so you can catch me, So just a quick overview of our data. We had a lot more females than we had males in our study. And we had a lot of patients who came from the stage 3 onwards. So it kind of ties in with existing research. And a lot of them were from the Telugu states. And the time since diagnosis is an interesting one, that they've spent a large chunk of their time at tertiary care centers ever since the time that they've been diagnosed with the fact that they have cancer. And largely, again, if you can see, they're either gynecological cancers, breast and ovary, or they're metastasized cancers, which means that, they've moved from one location to another, which is only, indicative of a bad prognosis. So our very preliminary findings, and I'll rest over here for a bit before I go on to my last slide, is that the presenting complaints were associated with help seeking, which means basically, if the presenting complaint was a pain in your uterus or in your lower abdomen, then you probably are not seeking help immediately because it's embarrassing. When we started interviewing oncologists for another study, we've come across a lot of gynecological oncologists who say that, a lot of women who have cervical cancer don't make it to the hospital in time. They've even come across situations where there are like maggots and all sorts in the cervix because everyone is so embarrassed about bringing this poor woman to the care center for help. And only when the stink gets really bad, they're brought to the care center. So that's horrifying to know. So it depends really on what type of complaint they have. If it's a lump in the breast, again, it's an embarrassing thing to admit, so they don't tell, and therefore they end up late at the hospital. Same thing goes with prostate cancer. The one that's most easy to kind of, as a presenting complaint is pain in your facial region and in your stomach, and high fever. Now, the time taken between diagnosis and help seeking, this is very crucial, at least for my arm of the study, which was psychological and behavioral, where we wanted to look at once you know you have cancer, how long is it taking you to get to actually getting your first round of treatment? And what we found was where you live makes a big difference. So if you're in the city of Hyderabad and in access to a cancer care specialty hospital, then it's very likely that you're seeking treatment immediately. But if you are a little far off, you don't have a care facility that is, specialized in cancer, then it's less likely you're getting treatment in time. The type of cancer you have, and as you can see, also it ties in with the fact that if it's a female cancer, it's less likely that you end up getting your treatment. And then the stage of your cancer also matters. So if you feel like, if the patient realizes that they're in a much later stage of cancer, then there's a lot of debating that goes on, whether it's even worthwhile. Sometimes it's about worthwhileness of coming for treatment, and another time it is also the fear that, I might die, so let's just delay this business of treatment. Gender was associated with help seeking, and this is something that is very crucial to how our future research is starting to pan out. So we're starting to look at gynecological cancers more carefully because our experiences as researchers on the field and our work in our actual empirical work is all pointing towards the fact that there's a lot of gender discrimination going on in terms of care seeking and care provision. And the level of education was associated with the number of hospital visits. Now, this was also very interesting for us because the education level was not associated with how quickly they reported, but the number of times that they were coming to the hospital, because that meant that they were willing to, turn up at the center more frequently and interact with healthcare staff more frequently than somebody who has a poorer level of education. So I just wanted to wrap up by, sorry, I didn't realize that it would be so sunny, so I used red. Maybe I should have used another color. But the first point is that female cancers needed a bit more attention. So it's important to understand it from the community perception of not just cancer, but what a woman is and what her role is and how is it that, she's less in the radar of concern. And also understand how women are accessing care versus how men tend to access care, just so we can try and map their behaviors. And understand that we need to increase medical literacy overall, and this can be done through these psychoeducation programs where symptom reporting identification can be embedded into their education. And definitely public health messages are paramount, especially those that are pro, certain kinds of behaviors and gender as well. And finally, once they reach the primary care center, empowering or increasing the capacity and the skills of the Anganwadi worker and the ASHA worker in order to get them to understand how to communicate and how to communicate empathically. Something that we had also discovered during data collection is that the worker at the primary healthcare facility also did not give it as much importance, those symptoms, because cancer symptoms can be pretty benign until they become really bad. So, they themselves don't identify it, but also the real life problems are vaster than the symptoms that they present with, so to speak. So that was something that we thought that might help the workers as well. So thank you for listening. And if you have any questions or feedback, that would be great to hear.
Those who work in the cancer field and who research on cancer in labs, are they also working on, say, a test whereby anybody can know whether they have or don't have cancer, just like an AIDS test, ELISA, either you have it or you don't. Because I believe late diagnosis is directly related to prognosis, and so early diagnosis, and some may be pretty complicated. You may have to do a biopsy in order to get a diagnosis. And so, I'm not a student of biology, but if somebody had cancer anywhere in them, is it possible to check something that will carry that message?
Well, I'm not a student of biology either, but there are two ways in which you can kind of early identification. One is genetic testing to get to know what cancers you're predisposed to so that you can alter behavior accordingly. And the thing about cancer is that it's a very unique disease. It's not something like, AIDS or diabetes where one test is enough and then you know, because it's not a single organ disease. So there are tests for specific types of cancer. So you can do an ultrasound or a mammogram for breast cancer. There's a PAP for cervical cancer. So there are these kind of tests, but there's not one single test for cancer, unfortunately.
Will a lot more be done in terms of public communication? For instance, in cities, should there be large number of hoardings educating the public about
That would really help, especially more than educating the public that cancer is not such a scary disease.
that message.
Is that would be wonderful if there was more of those kind of hoardings than people telling that they have better equipment than the other hospital.
Some of these are just comments, and some of these are probably questions. I don't know. See, one of the things you said about family-centric decisions, I see a lot of positive inputs in family-centric decisions as well. That is one. And when you're talking about the label cancer, in a hospital, when you enter, the cancer wards are special, specific. They're away from the other wards, and there is no escaping the label cancer when you're visiting the hospital. And the people visiting you, and because we are a country where, you know, if the one person is in the hospital, you have 7-8 people visiting them. And there is very little chance of escaping the label cancer. I mean, it's just a comment. And when you're talking about late presentation, you also said at the end, you know, the symptoms are benign. And late presentation is something that I think it's also very characteristic of the disease itself, that, you know, you get to a stage where, you know, things are really out of hand. So, I mean, that's just one comment I wanted to make. And the one thing I agree with you is that stigma against moving to a hospice is really very high. And, you know, that is yes.
Thank you.